Okay, and welcome to the second session of the day, which is optimizing patient safety through behavioural modification. So another aspect of human factors. In the last session, we covered design, and in this section, we're covering behaviour modification or changes to practice. And this session is in association with ABHI, the UK's leading industry association for health technology, and you'll hear more about that in a short while. We have four friends with us today. So we have Mike Fairbairn, who is the chair of ABHI Patient Safety Working Group. We have Ian Duncalf, who is vice chair of ABHI's Patient Safety Working Group. We have Rachel Power, Chief Executive of the Patients Association, and in a change to the programme slightly, we have Helen Hughes, who's the Chief Executive of Patient Safety Learning. I'm first going to introduce Mike, who is going to talk to us for the first few minutes about his work. So welcome, Mike.
Thank you, Stephen. Good morning. Good morning, everybody. Yes, I'm Mike Fairbairn. I'm General Manager for BD for the UK and Ireland, but I'm here today as a board member of ABHI and Chairman of the ABHI Patient Safety Working Group. I thought it'd be useful just to give a bit of background to ABHI, the Association of British Health Technology Industries. We're a body which is the voice, really, of the health tech industry with key stakeholders in government, in NHS, and with regulatory bodies. And the health technology industry invents, discovers, manufactures, and supplies products, anything from syringes to wound dressings to surgical robots and digitally enhanced technology to really improve, save lives and improve outcomes for patients. Not only does ABHI and the health tech industry support delivery of healthcare, it is a major contributor also to the UK economy. We employ something like 121,000 people across our industries in the UK, 3,500 companies in the UK, generating a turnover of about £22 billion. The members of ABHI, there are about 300 members within ABHI, represent 80% of that 22 billion turnover. So that's just a bit of background to ABHI and what we're about and how we collaborate across industry to influence within the environment. Today, though, we're here to launch a paper, which is really a call to action to strengthen the partnership between NHS and industry. And we saw in the previous session, actually, some great examples of innovations and technologies that can actually make a difference in patient safety. So that's the aim, really, of today, is to launch the paper, which we'll say a bit more about towards the end. But to give a little bit more information on how we developed the paper collaboratively, I'm going to hand over to Ian, who's going to give you a little bit more insight on that.
So my name's Ian Duncalf. My day job is at Behavioural Medical. I'm a business unit manager, but like Mike, heavily involved with the ABHI Patient Safety Working Group as a vice chair. The Patient Safety Working Group is a cohort of 12 ABHI members and different companies and different charities, and we've worked very hard over the last probably 18 months to 2 years on the paper that Mike briefly discussed. So we've probably late 2018, we decided to put our collective heads together and came together to develop a paper that would provide key insights around six health events. And those are, I've written them down so I don't forget them all, are the antimicrobial resistance, falls and hospital bed injuries, healthcare-associated infections, medication errors, pressure ulcers, and sepsis. And those areas were identified through working and correspondence with Dr. Jonathan Gray, who at the time was Chief Executive for Patient Safety at the Academic Health Science Network in the Southwest. We worked very closely with him around those areas so we could develop this paper that would best represent the most impact across the board. And then the paper was backed by our experts on the sofa today, and they will probably delve into much more detail than I will. So I'll hand back over to Mike very briefly so he can introduce the speakers.
Thank you, Ian. So yes, the overarching theme of the paper is really around human factors and how human factors, when facilitated with technology, can really optimize patient safety. And we're delighted to have two expert speakers with us today. Firstly, Rachel Power, who's Chief Executive of the Patients Association. Rachel's had over 20 years experience in health and social care in the voluntary sector. I don't think she needs an introduction, but what Rachel's going to do is actually give us some context for the rest of the session, which is putting the patient's perspective when it comes to safety. So, Rachel, thank you.
How do I use the slide deck? So I'm technologically challenged, so I've quickly had to ask how to use the slide deck. So thank you to ABHI for inviting the Patient Association to come and talk from a patient's perspective on safety. So the first slide is I'm going to look at is what does safety mean to a patient. But first of all, I want to ask how many people in the room have heard of the Patients Association? Oh, brilliant. Okay, good. That's great. So there's kind of three main areas where we look at patient safety and what safety means to a patient. And the first is where a patient has been harmed deliberately, which obviously is a gross abuse of trust and thankfully extremely rare. The second is that patient is harmed by an error because somebody makes a mistake in something to do with their treatment. That might be to do with the wrong site operation or a pressure ulcer developing. The third is a patient harmed by a system problem, which I think we've heard quite a lot of over the last few days, people talking about what they've done to address system errors. And that could be where results are delayed or where the patient's treatment is delayed in starting. Or it could just mean they spend a needless amount of time suffering pain and discomfort. We often think of patient care in the context of hospital, but actually, and that is what the ABHI report has looked more within the context of the hospital. And obviously, when a patient is fully in the care of the NHS, then that is safety is especially vital. But we as an organisation want to think of patient safety and patient harm in the context of community services too. For example, the poor handling of people with mobility needs, or risk of falls, or pressure ulcers not being addressed. But also the issue that we want to kind of raise is it's not just to do with the NHS; it's a wider issue as well. And you know, think of patient being a frail patient being discharged from hospital, and some of the stories that we hear that community services aren't there and local authorities, so they need a ramp, they need some rails fitted. So we want to look at patient safety as an organisation across the realms of health and social care. Okay, so patient safety is not a new issue. For those of you who don't know, the Patient Association was set up in the 1960s by a part-time teacher called Helen, who set it up because what she heard about was reports on thalidomide babies, wronged patient operations, and tests on patients. So it's not new. First two of those are obviously very much patient safety issues, and the last one's very much a medical ethics issue. So patient safety went on. The 1960s, there were repeated scandals in a lot of long-term institutions. And for the next couple of decades, where treatment of patients in long-term care, usually people with mental health needs, the family members spoke up, but in a lot of cases, patients and relatives did complain, but they weren't listened to. And unfortunately, we still have some cases where the culture was wrong. I think you were all here yesterday morning when the National Patient Safety Strategy was launched. And it was really lovely to see that we were looking at what was needed for a patient safety culture, that we needed to look at psychological safety of staff, diversity, leadership, compelling vision, open learning. And it is scary that we're still here asking for an open culture, which I've heard from everyone over the last couple of days. And we saw some amazing awards last night from people getting awarded for what they've done around patient safety and what they continue to do. But as a member of the public and a patient, it is quite scary that we're still looking back, and we still have a resonance with Gosport mid-staffs. Sir Robert Francis is our president, and he was very much involved in the mid-staffs. So when things go wrong, the overwhelming amount, I've gone one step ahead. The overwhelming amount of patients have a really good experience of care in the NHS, and we know that staff work extremely hard within the NHS and social care. The idea that the NHS might harm you is really not on most people's radar until it happens. And then when it does happen, it's a massive shock. And we've heard, I feel like slide fake up here right now because we've had such passionate stories over the last few days from relatives, where we started the conference yesterday morning with Nicholas's story, which was extremely passionate. We've had Scott talking about what happened to his family with his son. We've had James talking about what happened with his son. And how these people have responded to what has happened in a shattering experience for them is to positively bring around change and positively look to build a legacy. But it leaves people very damaged because the shock and the horror and the upset the families have had to go through, where at times it has resulted in the death of somebody very precious to them. It can be obviously hugely traumatic for family members, and we need to get to a stage where that across the board, because I know in this room there's amazing cultures and I know there's amazing staff who will listen and who will want to turn it around, but we've got to get to a stage where that open and just culture is present across the NHS. Sometimes, and we run a helpline, and we've all seen the stories as well, sometimes the response just doesn't help. Sometimes for families, the shock of how the NHS has responded, patient and families who are harmed when something goes wrong, sometimes suffer more damage when they try to get basic redress. And I know that there was a session yesterday from Mother's Instinct where I was looking at, secondary harm. This isn't the focus of my conversation today, but it's a fundamental to any discussion on patient safety. The NHS Complaint System is often flawed. We do quite a lot of work with a number of NHS trusts in helping support them in developing their complaints process. And the amount of amazing complaints managers that I've spoken to who say that staff are still scared. Staff are still scared to admit that a mistake has happened. Then we have to change that culture to get that movement. It does vary completely from institutions to institution, but often the instinct is to deny and cover up because of the culture. I'm not going to name somebody, but they were one of the shortlists last night, and they spoke to me a few weeks ago where they had studied a number of complaints that had gone through their trust. And I think we heard it yesterday somewhere as well about it was the night staff who broke it. It was that team. We need to look at whole systems and work out why the whole systems are not working for the patient. Sometimes, all patients want, in a lot of cases, they want an apology and they want to know that this isn't going to happen to somebody else. And if that is the legacy that is left, that other people do not go through this. But I think there was a quote in yesterday's national safety, in the patient safety strategy, you know, that we could save 1,000 more lives. It's just that we could save 100 million in care costs. You know, those figures show why we really have to implement a strategy and a culture of openness. You know, I did complaints training for a number of years within my last roles, and the thing is, we all know in this room that if we listen to complaints and we learn from them, that it's a quality assurance, and actually we're going to bring more quality and we're going to bring more learning. And, you know, I've heard over the last couple of days, you know, what it's like in the frontline staff. It isn't helpful that there hasn't been enough investment around capital and workforce and training, so we get all of that. But we do call we, as an organisation, we do call out to try and attempt to get more funding in those areas. Because the cost to patients is unacceptable, but actually the cost to the NHS is, you know, if we can bring down that compensation bill, then we can invest that more back into services for patients. But I'm not going to go into any more of this because that's not what I'm here, but I do think we need to kind of cover that. So what are the solutions? So the patient safety strategy yesterday talked about a strategic aim was to establish principles and expectations for the involvement of patients. And we completely welcome that. But we have to remember that it's the NHS as a duty of care to patients, not the other way around. There are ways of bringing patients in. Firstly, we know that patients can be hesitant to speak up if they're unsure about a decision or if they perceive that something might go wrong. And again, we saw some clear examples of that over the last couple of days. And although they might be right, especially people with long-term conditions who understand their treatment and understand what they need, they just don't know how to raise it, and we've got to work to empower patients to do that. There needs to be empowered to speak up. There needs to be proper, we have all these words about empowerment and patient-centred care and person-centred care, and how do we get the patient right into the middle of their care, especially if that's where they want to be and they know their conditions. They need to know that there's a clear plan, and they need to know what it is and where that clear point of contact is for patients and their families. You know, effective care planning also addresses the risk of responsibilities falling through, which we've heard quite a lot of over the last couple of days as well, especially when a patient has more than one condition and two different professionals might be involved in the care of it. In some cases, there are technology and going around out there yesterday, and some of the work that ABHI and other organisations have been doing on technological advances that can help to control risk. I think it's air surfaces for pressure ulcers, all of those kind of areas. There's stuff out there, but we do need to engage patients to get them to understand what that is all about. And I've just gone on to Helen's slide. I hope you found that helpful, and I think we're taking questions later. Right.
Thank you, Rachel. Thank you, Rachel, for giving us that context and the patient perspective and the impact of safety. As Stephen said, we have a change of speaker, and Professor Jane Reid sends her apology. Unfortunately, she's unwell, not able to be with us today, but I'm delighted we have such an excellent substitute, if I may say that, Helen. Helen Hughes, who's Chief Executive of Patient Safety Learning. She's had a long career in leadership roles within the healthcare in the UK, within the World Health Organization, and at the National Patient Safety Association. So a lot of experience around patient safety. So delighted that you could join us, Helen, and if you could take us through, I guess building on what Rachel has said, to how this links to human factors. Thank you.
Well, thank you very much, and thank you for giving me the opportunity to present today. Sorry that Jane's not here and she's unwell, but it does afford us the opportunity to share with you a little bit about our thinking in patient safety learning. And I am going to ask how many of you have heard of us, and I don't expect as many as for the Patients Association. So, hands up. Yes, so at least 5 people actually work for the organisational trustees, so thank you for that, and not so many others. Well, that's fair enough. We're a new charity, and we were set up as a charity last November. We're on stand 47 in the exhibition hall, so please do come and visit us. And I want to talk through a little about ABHI's work, and with the theme of human factors and system thinking, which is very dear to the heart of our work at Patient Safety Learning. As I say, we're a small charity, but we're intending to be very action-orientated. I think patient safety is on a journey. 15, 20 years ago, we just didn't know the scale of unsafe care. We didn't know the issues that were informing patient safety. We do now. We know a lot of what we need to do, but we now think is the time to move into the how, so that we have the tools, we have the resources, we have the professionalism to be able to apply that and make the change. So that's what we hope to do as a charity, to contribute to that. And having read ABHI's report, which I commend you to read, it's brief, but it's very focused, and it highlights those sort of 6 key areas on safety. But at the heart of the report, they highlight human factors, behavioural change, a commitment to learning, and proper investment in patient safety, and I completely endorse those. What I've put here also is partnerships for patient safety. And one of the things that we emphasise in our work as we're developing our work at Patient Safety Learning is that we need to work within a healthcare system. And that system is a really big and quite complex system. And when we talk about patient safety as a strategy, that needs to include policymakers, system regulators, professional regulators, providers, commissioners, patients, product manufacturers, everyone that works in healthcare. We should be having a system-wide approach to patient safety and one commitment to change safety. So welcome ABHI's commitment as industry to partner with healthcare for safety and to design safe systems in promoting that cultural and behavioural shift. So I'm going to talk a little, only a few slides about patient safety learning. And I mean, Aidan talked yesterday, 11,000 avoidable deaths a year, volumes of reporting, and I have to admit, being part of the setup of the NRLS and the fact it's a data repository, it's not yet quite a learning system. So we've got a long way to go to meet the ambition of Liam Donaldson's organisation With a Memory when that was published in 2001. So we've still got too many patients suffering harm. We are wasting an inordinate amount of money in responding to that harm, either the cost of negligence or retreating or losing very valuable staff because it doesn't feel safe for them to work in a healthcare system. And in our report, A Blueprint for Action, which, little summary here, but we can pick those up on the stand, we reflect that that's, in the NHS alone, it's about £5 billion a year. Now, that's a lot of money that should be better invested in making safer care. So we think just doing the same isn't going to get us the scale of change that we need, and we need to think and act differently about patient safety. So some of our proposals are, and obviously in this strand and being supported by Steve and his excellent presentation this morning, about design for safety. I think as we've gone on this journey, there's been a tendency to really focus on the importance of learning from harm and error, and valuable as it is, but it's more about designing for safety. What does good look like? And redesigning the work as done rather than the work as imagined. So So actively seeking out safety problems, using near misses and insights from our frontline clinicians and non-clinical colleagues, implementing that good practice in organisation and sharing that broadly, redesigning using systems and human factors, and finding tangible examples of where people are doing that. The recent work that I've seen at Liverpool and Broad Green Hospital under Neil Jones's leadership as Assistant Director of Human Factors and Patient Safety, some excellent initiatives that are making a real difference. Getting sourcing those, sharing those insights and allowing people to build on that work is something that we really want to support and promote. We could spend an entire day talking about culture, but for me, it's making it safe for staff to work in healthcare, and we know that many feel that they're in an environment of blame and fear, and that does not support safe practice. Patients as partners is absolutely core to our thinking. Patients as partners, not only as members of the healthcare team in receiving their own care, and I agree with Rachel, it's the responsibility of the healthcare system to ensure patient safety, but patients and families where they want to can contribute to that. And we've been doing some work, and we'll be developing that this year, looking at how the models are good practice for that, how patients and families should be better supported and engaged when things go wrong, and how the patient voice in terms of advocacy is so important, and how we can develop and share that. Unlimited opportunities around better use of technology. We know that there's an ECRI study in the States that shows one of the biggest concerns around medical technology by clinicians is the failure of electronic systems for safety. They're introducing new big systems, sometimes unintended consequences, and makes it unsafe, less safe. But used effectively, either by equipment or IT, if you design for safety, those are the forcing functions that help staff work in those environments, rather than reliant on training or checklists or procedures. And critical for us, as you'd expect with a charity with a name, Patient Safety Learning, it's about sharing learning and insight of all of that. So we don't want to be known as an organisation that just produces reports. Though we've produced some reports. And we produced a green paper on patient safety, Patient Safe Future, last September, and consulted quite widely on it. And I know that there are many people in the audience that contributed to our thinking by responding to that. And thank you, because the wisdom of crowds is better than the wisdom of the few. And what we've produced is a document, quite lengthy, but quite detailed, and hopefully helpful. And it's called a Blueprint for Action, and it focuses on these 6 foundations for patient safety that we think we need to pay more attention to. And in it, we identify what good looks like, and also what action we think needs to be taken to get there. It's not just our ideas. We've ruthlessly sought out excellent ideas from other industries, but in healthcare in the UK, but broadly, and have focused on these 6 foundations, which I'll just briefly mention. And there's a lot more detail in that, so do look up on our website. Shared learning, I'll come back to that. Core critical about knowledge being trapped within organisations and sharing learning. The awards last night were a fantastic showcase for some excellent practice, but we need better ways, I think, of sharing and enabling other people to build on that excellence. We think we need to professionalise patient safety, and Alison Leary, who we're delighted is one of our trustees, she talked about this at yesterday's session, about resourcing and training and having the expertise around safety and around human factors to help us design safer systems, and to make sure that we have a competency framework on safety for everyone that works in healthcare, not just specialists, that, like people in this room, but porters, non-executive directors, clinicians. Everyone needs to be suitably qualified and experienced for safety. Leadership, we really drive home the idea that patient safety shouldn't be just a priority. That sounds a bit bizarre. But we think at the moment patient safety is a priority, but it's one priority of many. And we don't think that's the right approach. We think safety should be the core purpose of what we do. And that should be the lens by which we design and deliver our healthcare. And we've got ideas and contributions from others of kind of leadership models that we should look for. Safety data, a lot of the data that we have, the metrics are around incident reporting. They're retrospective data of harm. They're less predictive and they're less about how do we know that we're safe. So we think much more work is needed to collate the data that we routinely collect, but looking at it from a safety perspective, but beginning to look at ways of monitoring and collecting data on safety rather than just harm. And the safe culture, which I mentioned before, a key theme throughout it all, but at the heart of it is all about the outcome for safer care for patients, and that's the lens that we need to look at. So what would a patient-safe future look like if we address all that? And again, the report explains a lot more, but patient safety is a core purpose, and people can honestly say that in their work and in their priorities and in how they resource and fund organisations and how they set organisational goals. That there are standards for patient safety. We know a rather bizarre comparison maybe, but if you work for fire safety, the NHS has very, very clear standards for fire safety, how it's expected to be managed, who has the expertise, what the goals are, a safety system operates around that, it's monitored, it's regulated, it's transparent. We haven't yet matured in terms of patient safety to having that framework, and we think there's value in doing that. We've talked about staff being suitably qualified and experienced for safety, and delighted to see NHS Improvements Strategy making reference to this. It isn't just about the knowledge base, it is about staff having skills and behaviours and the resources to do that role. Patients being core members of the team, their clinical team, but the safety team, better measurement and reporting. A culture that prizes safety and promotes learning, and that learning is shared and applied quickly and easily. So this is a shameless plug for one of the areas where we want to contribute to improve safety and some of those actions. And one of the actions that we're taking as a charity is we launched this yesterday. It looks slightly different, we retitled it, but it's the hub. It's a learning platform for patient safety. It's a knowledge platform. You can use it without signing in if you want to, but if you sign in, you get more functionality. It doesn't cost you anything. It's free at the point of use. And the thinking behind it is informed by work that we were doing a year or so ago with Professor Carl McRae, and the challenge about knowledge being trapped in organisations, and how do you find knowledge around safety? What are the problems that other people have? How have they responded to them? How have they improved them? What have they learnt? What would they do differently? How does that knowledge get shared? And what the hub does is have an area about learning. So there's a lot of content already on there. Around patient safety. We want to capture as much new content as possible. The excellent examples from the awards, everything that you're doing that you want to share and share with colleagues. If you're a member of the hub, if you just sign up for it, you can share knowledge and engage in communities of discussion about how best to do that. And then it gives you also the opportunity to sign up to alerts and news. And so we would welcome contributions from industry, from patient groups, from clinicians, from individuals, from organisations to make this a truly amazing resource on patient safety knowledge. We're focusing it particularly at the UK at the moment, but once it's out on the internet, it becomes global. So Tippy-Toe Days, do register, do share your insights with us, because then we will have a real repository of knowledge that we can collectively use to improve safety. So thank you very much. Thank you.
Thank you very much, Helen. And I think the hub is an excellent idea for creating this community of patient safety across multiple organisations and stakeholders involved in patient safety. So just to, finalise the session, we talked about our paper from ABHI that's been produced. There's a few copies, I think, on the side over here. But within your program, there's also a QR code which you scan, and that'll take you to a copy of the article as well. And so please do have a read, as our excellent speakers have said. But I think now, Stephen, we have time for some questions.
We do.
Thank you.
If we could have the Slido questions, please. We've probably got a few questions from our audience. So yeah, we've got a few. And the first question was one that I was going to ask genuinely, if there was a delay. So how do we get patients' feedback and get them to come forward? So how do we approach patients? Practically, how do we do it? Or do we wait for them to make a complaint? So yeah, it's on the how. How do we get that knowledge? And Helen, first of all,
okay.
would you like to?
Well, we're doing some work on this, and we'll be preparing a report later in the year. So one of the things we want to do is capture examples of good practice that currently exist now. So rather than starting with a blank sheet of paper, I think it's really important that we capture patient feedback at the point of care. So that's about engaging in enabling staff to listen to that feedback and finding ways of doing it that it doesn't put patients in an immediate adversarial position. We know that there's a lot of work, particularly in the States, in paediatric care, where you've got opportunities to raise concerns or escalate matters. If, as a parent, you're concerned and you don't think the clinical team is listening, there's somewhere else to go. So there are mechanisms for doing it at the point of care, and we need to learn more about those ones that work and share that knowledge. I think there's an enormous amount around patient feedback when things go wrong, and I used to manage the Parliamentary Health Service, Ombudsman Service, the Complaint Service. So I've seen at the top tier really the kind of awful responses to complaints that sometimes the system responds to. So I think it was going back to some reports back in not long after Francis, saying that we need to use complaints as a rich source of learning. So those examples. And also, I think in terms of patient advocacy, finding mechanisms to engage and get those voices. One of the things, the hub is obviously very new, and it launched yesterday. I would love it to become a mechanism for people to share, but I think there are other vehicles that work very well. Care Opinion. How many people here know of Care Opinion or use it? See, that's not very many, and I think it's a really fabulous tool that many organisations are working, and that gives patients and service users the opportunity to respond back to that organisation that they receive the care, and it's a safe space to do that. It's a fabulous tool. So one of the things we will do will be to try and collate all this evidence of good practice and share that, and clearly working with Patients Association, AVMA, and patient groups as well.
Thank you. Rachel, would you like to add anything to that?
Yeah, I would. I think it's part of that question, which makes me feel so good, is that, absolutely we shouldn't be waiting for patients to complain. And we see so part of the work that we have done with a lot of NHS trusts is done patient-focused reviews of feedback mechanisms and different ways of getting feedback. And it is definitely about the patient advocate within the hospital and the role of the patient participation groups that different hospitals have going. And one of the ways that we're looking with supporting a hospital through one of our organisational memberships is around how, as an organisation, they can run genuine surveys, genuine independent surveys, and how we can analyse those, because they're doing a fantastic job in changing the culture. They think within the hospital. I personally think they are doing a fantastic job too, but actually they need the mechanism from patient groups to prove that there is a difference. So I think the use of kind of patient focus groups, the use of surveys at discharge, there's quite a few different ways we can do it, but if anyone wants to talk more, I can give you some more examples from work that we've done.
The next question is an interesting one, I think, with regard to Safety 1 and Safety 2. Why do we always focus on negative events or what went wrong? We should focus on what went right in the majority of cases, which is more of a statement than a question. But I guess the question that arises from that is, how can we better understand what goes right? And I'm wondering from the technology point of view, if there's anything that can help us to amass this kind of data that you're aware of?
Yes, and I think it's a great question, and I think part of the revolution that's happening within healthcare is through digitally enabled technologies and capturing data and turning that data into what we would call actionable intelligence, if you like, information that clinicians and people can work on. I guess a simple example of that would be this push within the hospital environment towards interoperability, so connecting all of the technological devices, whether it be an infusion pump or dispensing technologies, to the electronic patient record, and being able to interrogate that to give better insights. And it's not just to track when things have gone wrong, it's actually to optimize utilization of those technologies or the drugs that are given or whatever. So I think that's one example through digital technology that can provide actionable intelligence to people caring for patients.
Another is the excellence reporting, which Emma Plunkett and Adrian Plunkett down at Birmingham, I think, have been involved in, and how you can actually encourage more reporting of what you appreciate, perhaps, in a hospital. Let's go on to.
Please. I think it's trying not just to focus on reporting.
Yes.
So, I mean, I've been talking to a colleague Claire Cox, who I work with, who at Patient Safety Learning, who still does clinical work 1 day a week, and we've been discussing about the challenge of how to capture things like near misses. So if you're on a ward, or you're working in a complex system, and you see things, what do you do with that knowledge? People just don't have the time to report near misses, and they're huge volumes. And even if they do, I'm not sure organisations are necessarily ready to respond to those. So it's kind of how you use those kind of feedback loops from staff and not just thinking about reporting. So even, the 2 million annual reports that go into the NRLS, it's only a small number of those that get reviewed. It's kind of, where's that rich insight, and how do we do that? And how do we find different ways of engaging with colleagues, just to say, look, I think this could be improved. How does that get into, and how is that responded to in an organisation? So it's kind of moving from responding to harm to designing for safety, really.
Yeah. I mean, as a patient myself, I recently had an operation which went wrong, followed by a corrective operation which went wrong, which was about a 1 in 100,000, I think, combinatorial probability. But with the first surgeon, I had a meeting for about an hour or two, and then I understood how rare it was for the operation to go wrong in this way, and I felt no need to complain about anything, because we'd had a personal discussion. And so, as you say, it's not always about reporting; it's other things.
And I think that too. I think sometimes staff here, patients want to tell good stories as well, and part of the work that we've done in some of the trusts that we've gone in and work in is actually trying to gather that, what did good look like, and actually I think probably staff sometimes hear those stories and need to take those stories and say, wow, this is how it went really well. So you had the information you needed. Actually, what elements did I participate in that made that a good outcome? And look at how we can do that within multidisciplinary teams and develop it.
Let's take a final question close to my heart before we finish. What elements of mental health and learning disabilities care would the panel like to include in this initiative, aside from parity of physical care? Who'd like to speak to that?
I'm willing to start from a patient perspective. When I was standing up talking, I wasn't just thinking about physical care. I think we need to think about the whole person and the person's needs, and be that where mental health needs are there or learning disability needs. And it's about our ability to listen and to communicate against what that person needs, and making sure that the advocates for that person are there. So I'm forever talking about the whole persons in whenever I think about anything, because I think if we think about a person and with their one condition, then we haven't got a chance of getting it right for the patient.
Okay, we have just one more time for one more question in the last minute. Recommendations for driving culture, not a difficult question, for changing culture, and it's moved to the top, and learning. Just a practical thing, instead of culture change, let's talk about practice change. Just a practical thing that people here could do. Any quick takeaway practical thing that you'd like to see more of?
In terms of culture or sharing of learning? Sharing of learning, well, find ways of communicating what goes well. I mean, obviously, we are identifying, we're providing a product called the Hub that will enable people to do that. Do look at it, do think if it has a use for you, it would be great to share that, the kind of wisdom of crowds, lots of people sharing good stuff. I think it's if you're in a leadership role in an organisation or a leadership role in a team, it's finding the space to be able to learn and to get that feedback. And I think that's... we were talking last night at dinner. I mean, it's finding, there are tools like after action reviews. They don't have to be very time intensive, but they can be quite quick. And you just get into a different mindset of how did that go? What were we expecting to happen? What should have happened? How could we do that differently? How can we and our colleagues learn from that and move it on? And, just having that kind of natural way of kind of learning, trying to build some of those tools in. I mean, you said you found it really successful.
Yes, it's something we've implemented within our organisation to bring learning more quickly into the organisation. So.
Rachel, did you have something to say?
Yeah, I think going back to my thing about thinking about us as individuals, as a whole person, but actually acknowledging and using the patient's knowledge of their condition and their needs and where they want to go to. Their vision.
And last word, Ian, on the tech side, what's the future from the opportunities of tech when it comes to changing practice and influencing culture?
I think it's just forming a partnership between the medtech industry and healthcare, and understanding the value of the future and the industry, and understanding the value long term as well, not just the short term value as well.
Okay, I'll let you have the last word, and that takes us up to lunchtime, everybody. Thank you to our panelists and speakers. Please join me in a round of applause.